everyone. Good afternoon and welcome to today's session. Thank you all for joining us once again as we are observing the September, which is the Childhood Cancer Awareness Month. We are privileged to meet again for the second session of Pediatric Oncology series. Last week we met same time and we talked about leukemias and lymphomas. And today we are going to be talking about solid tumors in children. And this afternoon, we are privileged to have our speakers, our two speakers. Our first speaker is Dr. Sarah Muma. She's on our screen. Sarah is a pediatric hematologist oncologist working at the Kenyatta National Hospital. And Sarah Muma trained for both her undergraduates and postgraduates here at the University of Nairobi. And thereafter, she proceeded to South Africa at the Free Hospital University, where she trained in pediatric hemato-oncology. And she also has a master's in advanced oncology from ULM University, which is in Germany. She'll be taking us through an overview of the childhood solid tumors. Then we have our second speaker today, Dr. David Wata. Dr. Wata is a clinical pharmacist working at the Kenyatta National Hospital. He's in the pharmacovigilance drug and information unit. He trained also for his undergraduate and his master's in clinical pharmacy at the University of Nairobi. And we work together with him very closely, taking care of the children with cancer at the Kenyatta National Hospital. I'm your moderator today. My name is Irene Zamu, a pediatric hemato-oncologist, also working here in KNH. So we welcome you for the meeting. Feel free to type in your questions in the Q&A chat. And we shall now start. I welcome Dr. Sarah to take us through the first session. Karibu, Daktari.
Thank you very much, Dr. Irene. And thank you to the KNH research team for this opportunity to present and to discuss on childhood solid tumors. I'll just share my screen. Put a slideshow. Okay. So we're going to do an overview of childhood solid tumors. There are very many childhood solid tumors, so we're just going to talk a bit about a few of the common ones that we see in KNH and generally in Kenya. The outline of our discussion today, we're going to go through the epidemiology, look at signs and symptoms of childhood solid tumors and how to make an early diagnosis. And also we'll look at an overview of some of the solid tumors. The ones we're going to look at a bit more are Wilms tumor, neuroblastoma, rhabdomyosarcoma, osteosarcoma, and brain tumors. And then we'll later discuss the principles of management, just an overview of how to manage childhood solid tumors. We do see many other types of solid tumors. We also see germ cell tumors, hepatoblastoma, also commonly, less commonly, we see others like nasopharyngeal carcinomas. So we do see other solid tumors, but for today, we will discuss just some of these and we'll cover them even more extensively during our upcoming workshop later this month and also cover on other solid tumors of childhood. So by way of introduction, cancer is the second leading cause of death in children that's under 15 years in the developed countries. But in developing countries, of which Kenya is one, we now have a rising contribution of cancers to childhood deaths, though most of the deaths were generally due to infectious diseases in developing countries. The leading childhood cancers in the US and in Europe are mainly leukemia as the leading cause, followed by brain tumors. But you would say that in Africa, our leading childhood cancers are mostly Burkitt's lymphoma, nephroblastoma, and non-Hodgkin's lymphoma. Nephroblastoma remains the most common solid tumor in Africa. It exceeds 10% of the total pediatric cancers in many of the countries. So this was a study that looked at the patterns of distribution of childhood cancer in Africa. And they found that, for example, in Rwanda, nephroblastoma contributes 21%, in Senegal, 22%, in Ivory Coast, 14.5%, Mali and Congo also, you can see quite a significant contribution of their most common solid tumor they would find is nephroblastoma. This just shows us the top cancer per country. And you can see the yellow shows leukemia being the top cancer in children. That is in the year 2020. And you can see that in most of the developed countries, leukemia is the leading cancer. And in Africa, you can see that certain countries, now leukemia is the leading cancer. But then still in many other countries, non-Hodgkin's lymphoma are the commonest, and then followed by kidney tumor. So you can see for kidney, mainly they're referring to nephroblastoma. So Wilms tumor is still leading in many African countries. And it's thought that this is because of the manner in which it presents. So as a solid tumor, you know, there's something obvious, there's an either abdominal mass or abdominal swelling. And so it's quite clear. But for leukemia, there are many other confounders for us. We can find that children are being treated maybe for malaria, and just being transfused as anemia. And so many times the diagnosis is being missed, but as countries improve in picking up these early signs and symptoms, then leukemia now moves to the top on the most common cancer scene. And so for us in Kenya, that's a sign that actually we are picking it up more now that it's also becoming the leading cancer that is seen in Kenya. But still, among our solid tumors, we'd see nephroblastoma among the top of them. So the types of solid tumors seen in children from 0 to 12 years, and that's the age group that we take care of. These solid tumors will make up about 30% of all the pediatric cancers. And as we said, these are the most common types of the solid tumors that you're going to see in children. But there are many other types as well, which we also see. This is data from the GloboCan 2020. So GloboCan looks at various registries, mostly population-based registries and registries in various countries, and even data from institutions to collect and try and estimate the actual number of cases of cancer in children and even in adults, generally in countries. So for Kenya, the number of new cases that were estimated in the year 2020 was 2,283. You can see in yellow, the leukemia were the highest, followed by non-Hodgkin's lymphoma. And then our close third there is our kidney tumors, especially nephroblastoma. Hodgkin's lymphoma as well is quite common, 7%. And then the brain and nervous system now contributes 6.8%, which is an increase from before. Then we have Kaposi sarcoma and nasopharyngeal carcinoma. Then the rest have all been lumped as other cancers, but because these include, for example, our rhabdomyosarcomas, the germ cell tumors, hepatoblastomas would be in here. So there are still very many solid tumors that are contributing these other cancers, just that they were not broken down. And they're actually the majority where there's very many different cancers that have not been specifically grouped so that we can see how much of their contribution this makes. So that's why it's so important that we start collecting our local data to show exactly the distribution of cancers in children. Some of the challenges we face in Africa overall, which make diagnosis challenging. One is the various comorbidities, for example, malnutrition and malaria, because of how we have malaria commonly in various places. It's easy for many of these children who may be having a malignancy to be treated for malaria, and that can delay the diagnosis. HIV and tuberculosis. So these also may present similarly like malignancies. For example, the lymphadenopathy, even sometimes if they have abdominal lymphadenopathy, we also know the constitutional signs in many of our malignancies, fever and weight loss. These can also present in tuberculosis. And so many times some children have been begun on treatment for TB, and this now, by the time they eventually get diagnosed to be having a malignancy may result in late presentation. HIV also, the prevalence of HIV means that many times some of the cancers we see may be related to that, though that has reduced with the treatment that is going on for HIV. So for example, Kaposi sarcoma. Then low socioeconomic status and poor resources allocation. Many times patients are unable to access healthcare because of cost, whether it be cost of paying their NHIF, cost of transport. And so those challenges result in a lot of delays in presentation. And so we may see certain cancers and some we may not see just because the patients did not access the health system. Poor resources allocation, we know that many of the healthcare workers who maybe would be necessary for treating childhood cancer may not be located in some of the areas where we may have also a high prevalence, and personnel lacking in some areas. So survival is poor, between 5% in Northern Africa, 34% in Egypt, and 70% in South Africa. So generally survival in most of Africa is very poor and less than 50%. In one study which looked at the influence of health insurance status on childhood cancer treatment outcomes in Kenya, this was carried out in Moi Teaching and Referral Hospital, they found that the childhood cancer event-free survival was 29%. And a lot of patients were unable to complete treatment because of financial constraint, and especially a higher risk of absconding or not completing treatment was because of lack of NHIF or just the health insurance status. Survival rates in developed countries, on the contrary, are between 80 to 90%. So we still have a lot to do to approach those survival rates that are seen in developed countries. Looking at the causes of childhood cancer, largely the causes are unknown, but some cancer predisposition syndromes exist in a few of the cases. So these are just a few that I picked up, which we may look at how they are related to certain cancers. So for example, if a patient has congenital anomalies and you look and see that they have aniridia, then you can consider this WAGR syndrome, and the risk there is that they can develop Wilms tumor. Patients with facial dysmorphism who may have a web neck and flat nose bridge, that would look as Noonan syndrome, and the cancer that they are predisposed to is leukemia. So looking at all these other characteristics, you can see the various syndromes. For example, Beckwith-Wiedemann syndrome, where children present with hemihypertrophy, and therefore they have growth disturbances. You may note, certain parts of the body growing faster than others or appearing larger than other parts. And they are predisposed to Wilms tumor, hepatoblastoma, neuroblastoma, and rhabdomyosarcoma. And Diamond-Blackfan anemia syndrome has also been associated with a risk of developing osteosarcoma. So there are certain solid tumors for which there are some predisposition syndromes, but these contribute a very small portion of the causes of the cancer. And most of the time, the etiology is actually just largely unknown. So this chart tells us it's very useful and should be put up in as many centers as possible because it just alerts people to the warning signs to look out for. So healthcare workers, when they note some of these warning signs, at least can start to suspect whether there might be a malignancy and investigate a little further, even as we look out for any other causes such as infection or anything else that could be the cause of these symptoms. But generally, when these are noted, there should be at least some suspicion that maybe there could be childhood cancer and you need to investigate appropriately. So the ones especially that point towards solid tumors, for example, number 2, we have lumps or swellings, especially if they're painless and without fever or other signs of infection. So generally just swellings developing on any part of the body. In this picture, you can see they are pointing towards some lymphadenopathy there, but these could be anywhere else on the body, and we'll talk more about what type of cancer to look out for. Then unexplained weight loss or fever, persistent cough or shortness of breath, sweating at night. These could certainly point towards lymphomas, but also any other malignancy in the okay. Then eye changes, for example, a white pupil, if the child develops a new squint that they never had before, any visual loss. And for visual loss, sometimes these children may just, if they're small and are not talking, for example, those who are under a year old, they may just start bumping into objects. For a child who was walking very well or already crawling, but you start seeing they're just bumping into things. So that visual loss, bruising or swelling around the eyes. So generally the white pupil points most commonly to retinoblastoma. Even the new onset squint could be retinoblastoma, but brain tumors as well could present with that visual loss. And then the bruising or swelling around the eyes we may see also sometimes in neuroblastoma. Number 5, the abdominal swelling. Many of these abdominal swellings in children end up being treated as worms, constipation, and at times some of these are actually masses. So when abdominal swellings are noted, and especially usually painless, but some may have pain, then suspect malignancy. Headaches, especially if they are unusually persistent or severe and accompanied with vomiting, especially early morning or worsening over the days, then that should also raise suspicion for brain tumors. Limb or bone pain and swelling without trauma or signs of infection should also make one suspicious of osteosarcoma, but even rhabdomyosarcoma if it's just more of tissue swelling than the bone. Then fatigue, lethargy, and changes in behavior. For example, a child just suddenly being withdrawn or having excessive somnolence, then those should raise suspicion of a brain tumor. And dizziness, loss of balance or coordination as well could also point towards brain tumors. So overall, you can see that by having these charts somewhere where a healthcare worker is seeing children, be it nurses or clinicians or doctors, occasionally this might cause one to suspect, might this child be having a malignancy? So early diagnosis is important because if the child presents early, this is a prognostic factor in cancer. We need to raise awareness on the signs and symptoms that need to be looked out for. And just to show us an example, there was a study which looked at data from 3 population-based registries, that's in sub-Saharan Africa, in those 3 areas, Abidjan, Harare, and Kampala, where they examined children aged under 15 and looked at the stages of their presentation for various cancers. And the stage was a strong predictor of survival for each malignancy. For example, they observed now for their Burkitt's lymphoma, the 3-year survival was 88% for localized disease and 13% for advanced or stage 4 disease. So that's remarkable difference in the survival means that if we pick up these children early, we can start to improve the survival from childhood cancers. So we'll start with Wilms tumor or nephroblastoma. Renal tumors generally comprise about 6% of all childhood malignancies and nearly 10% of all the malignancies in children aged 1 to 4 years. And Wilms tumor is the most common pediatric renal tumor. It's a heterogeneously embryonal tumor. It's composed of 3 components, plastemal, epithelial, and stromal components. But other renal tumors that can arise less commonly in these children are clear cell sarcoma of the kidney, malignant rhabdoid tumor of the kidney, and also renal cell carcinoma. Most of the children who have Wilms tumor are diagnosed between 1 to 5 years of age, and the peak incidence is noted at around 3 to 4 years of age. There are congenital anomalies in about 12 to 15% of cases, and the most frequent would be aniridia, genitourinary anomalies, and hemihypertrophy. Most of these children will present with unilateral nephroblastoma, but bilateral presentation can be seen in about 5% of these cases. The initial signs and symptoms that may be seen in Wilms tumor, this was from data collected from children and how they presented, and just looking at what was the most common symptom of presentation. So a palpable mass in the abdomen was the most frequent, seen in 60% of the children. Hypertension was actually fairly common in 25%, hematuria in 15%, then weight loss, urinary tract infections, and other symptoms now included nausea, vomiting, abdominal pain, an acute surgical abdomen in some of those who may present with tumor rupture, cardiac insufficiency, which may present in those who may have a tumor thrombus going up the IVC into the right atrium, and then pleural effusion for advanced disease. So all these others contributed about 8%, but the most common symptom to look out for is a palpable mass in the abdomen, accompanying hypertension, and hematuria, which may not necessarily be gross hematuria, but may be microscopic hematuria seen on urinalysis. So making a diagnosis of Wilms tumor, history taking, as always, is most important. For example, ask about congenital defects, any previous benign tumors, and any history of malignancy in the family. And on physical exam, looking for these same congenital anomalies, which we mentioned, much as they are not very common, it's important to measure the blood pressure and also look out for hepatomegaly, as also we look out for a palpable mass. So the image on that side shows this was a recurrence from a previously treated Wilms tumor, but sometimes the mass is this obvious and many times may not necessarily be so obvious, but basically look out for any palpable mass. Lab investigations to do would be full blood count, our electrolytes and creatinine, just to check renal function, and many times it's okay. The liver function tests, uric acid and LDH, and also a urinalysis. As we mentioned, there could be hematuria. So how to make a diagnosis of Wilms tumor? Once a mass is palpated, at least an abdominal ultrasound is accessible to most of us. So an abdominal ultrasound would be the first thing that we should try do. And also CT scans now are more widely available, and an abdominal CT scan is recommended. It is actually considered diagnostic. There are features which are looked for in the abdominal CT scan. So for example, like in this one, you can see the kidney here looks normal. And on this side, you can see what we call the claw sign, which there's a normal rim of tissue, and then the rest of this is the tumor. Also, a chest CT scan is important for staging to look for metastasis, because the commonest site of metastasis is to the lungs. An echocardiogram is important, but that can be done at the treatment center. It's usually because of the type of treatment that may be required. Some of the chemotherapy may be cardiotoxic, and especially given to children with metastatic disease. But that can be done at a treatment center. Basically, for you to make a diagnosis, at the very least, try and get the ultrasound and then a CT scan, if possible, and then refer to a treatment center. Staging and risk stratification. We follow the SIOP RTSG, the Renal Tumor Study Group of International Society of Paediatric Oncology. That is the system we use for our staging, risk stratification, and treatment. We follow SIOP guidelines, which is the European approach. There is also the Childhood Oncology Group, which is more of the US approach, and the main difference between the two is that for the COG, they tend to do surgery upfront, but then for SIOP, we will give chemotherapy and then surgery will be done after the neoadjuvant chemo, and then continue with chemotherapy. Outcomes comparing the two have been found to be similar. So treatment is done according to risk stratification. This is based on the local stage and also on the histological classification. Based on the histology, the classification will be done into low risk, intermediate, and high risk Wilms tumor. And then the staging would be our stages from stage 1 to stage 4. And we also have stage 5. Then curative therapy is can be achieved in 90% of affected children, even those with disseminated disease, but this is data from developed countries where they achieve those cure rates. But survival disparities are there, whether between various countries and even just within. You may find that in certain areas, the survival is better based on many different factors, for example, access to chemotherapy and continuity of treatment. Nearly 40% of all the relapses which occur, it's because you'll find that the tumor may not have been histologically classified as high risk and needed to be. So here is the staging and risk stratification for Wilms tumor. So we have, this is just, I tried to simplify it, but the stages are 1 to 5. whereby in stage 1, we have fully resected tumor, which is limited to the kidney, and this is our PSYOP staging. And stage 2, tumor extends beyond the capsule, but is completely resected. In stage 3, we have residual tumor with lymph node involvement. We have tumor spillage. Those would factor stage 3. And stage 4 is when we have hematogenous metastasis. So this is to liver, to lung, and to bone marrow. And in stage 5, we have bilateral renal involvement, which is at diagnosis. And then for each of these stages, we include our histological risk stratification. So low risk is tumors which are found to be completely necrotic upon surgery. And then intermediate risk, we have those which are regressive type or a mixed type, then epithelial or stromal type, whereby now for the epithelial and stromal type, you'll find like the epithelial component contributes more than 2/3 of what has been resected. And then high risk, the blastema type, or where we have diffuse anaplasia. So usually after surgery, the treatment now includes this histological risk stratification so that not all children are exposed to high doses of chemotherapy, whereby we can reduce because for example, it's a stage 1 and intermediate risk, then we can give less chemotherapy as compared to one who may be, for example, a stage 4 and high risk. So this is helpful so that the chemotherapy can also be tailored to what they need. So that's just a brief about Wilms tumor. Next, we'll talk a bit about neuroblastoma. So neuroblastoma originates from primordial neural crest cells, which normally give rise to the adrenal medulla and sympathetic ganglia. So basically, it can arise anywhere along the sympathetic chain. It accounts for 7% of all childhood malignancies, and it contributes 15% of childhood cancer mortality, which is pretty high for the number of cancers that are actually neuroblastoma. Usually it will present with an adrenal mass or a tumor arising anywhere along the sympathetic neural chain. And the most common presenting feature is the asymptomatic abdominal mass. As we had mentioned, that's one of the common presentations of childhood solid tumors. Metastases are detected at the time of diagnosis in 75% of cases, which is quite a significant number. In infancy, so children under 1 year, this is the most common malignancy. And at diagnosis, 50% of the patients are under 2 years of age, 75% would be under 4, and 90% would be under 10. So basically, it's rare that we will see children above 10 years with neuroblastoma, but not impossible. The peak age of incidence is at 2 years of age. As we mentioned, sometimes you may find certain genetic predispositions, and those associated with neuroblastoma are neurofibromatosis type 1, pheochromocytoma, and then Turner and Noonan syndromes as well. So always good to look for anything suggestive of this, because these are important in also making a family tree and seeing whether any other child or family member is at risk. So the signs and symptoms. Basically, for neuroblastoma, as you said, it can develop in so many places because it will be anywhere along the sympathetic chain. So the clinical findings will be related to the anatomic site of the primary tumor. For head and neck, usually it will be a unilateral palpable neck mass, or they may present with Horner's syndrome, where you have meiosis, ptosis, enophthalmos, and anhidrosis. And then it can also present in the orbit and the eyes. The picture you can see there is the raccoon eyes because of orbital metastasis, and you may have periorbital hemorrhage. Then they may have exophthalmos and palpable supraorbital masses, ecchymosis, edema of the eyelids, and ptosis. In the chest, they may present with dyspnea, they may present just with dysphagia, and on imaging, you may see that there's actually a mass in the mediastinum. Abdominal, we've mentioned that's usually you can present in an abdominal mass, which is palpable. Pain may or may not be there, and anorexia and vomiting. The images you see on the right, you can see this arrow, which is pointing towards a suprarenal mass. As you can see, it's not part of the kidney. So this is an adrenal mass, which is mixed solid and cystic. And this is suggestive of neuroblastoma. On this other image, you see orbital metastasis, and you can see these masses which are pushing on the orbit. So you can see there's proptosis here. If you see the orbit, that on this one, we actually have proptosis. So other signs and symptoms, in the pelvis, you may have constipation or urinary retention, paraspinal area. So this may present with back pain, a limp, they may have paraplegia. Then the non-specific constitutional signs, which we said can still be present, but usually this may be in extensive disease, like weight loss, abdominal pain, weakness, and irritability. Then hypertension. Hypertension is a common presentation in neuroblastoma, and it may be due to renovascular compromise or catecholamine secretion. And symptoms which may be related to this catecholamine release, they're not very common, but they may be there, where the patient may have sweating, flushing, they may have pallor, headaches, and palpitations. The children will also present with paraneoplastic syndromes, which are because of release of VIP, vasoactive intestinal peptide, and this is secreted by the neuroblastoma cells. So the patients may present with intractable diarrhea and failure to thrive. And then if they have bone marrow metastasis, then they may have bone pain and limping. Smaller children, of course, may just have irritability. So how do we make a diagnosis of neuroblastoma? We've mentioned that there will be release of catecholamines, so it's good to check the levels, and these are the ones, HbA and VMA in urine, and these will be elevated. We may do a CT scan or MRI for evaluation of tumors. CT scan, again, because that is generally more easily accessible. So we may begin with a CT scan, but MRI may be more useful, for example, in evaluating paraspinal lesions, because it will permit that, as we've indicated, the evaluation of the interforaminal extension. So the mass may be extending through the foramina in the vertebral bodies, and that's, you can detect that better on the MRI. But at the end of the day, tumor biopsy will need to be performed. So that requires a consult to pediatric surgery. Bilateral bone marrow biopsies and trephine are required for staging of neuroblastoma. And the staging that is used, we have the International Neuroblastoma Staging System. And more recently, there's been another staging system known as the International Neuroblastoma Risk Group Staging System. So the INRGSS, this one uses pre-surgical assessment of the extent of disease. It's based mainly on imaging studies and bone marrow morphology. And what was previously there already, the INSS, uses the extent of surgical resection. It looks at lymph node involvement and metastatic disease for determination of the disease stage. So the INRGSS, this is before surgery, and INSS includes surgery, and resection will generally have been done. So the prognostic factors in neuroblastoma, there are certain clinical variables which can be used for risk stratification. Number one, the stage of disease, which we can use the INSS or INRGS to identify the stage of disease. The age is a significant prognostic indicator. Children who are 18 months of age and below generally do better than those who are 18 months and above. So that cutoff has been used in risk designation. Then for infants who are less than 6 months of age and have small localized tumors of the adrenal gland, there has been shown that spontaneous tumor regression can occur. So for such children, treatments can, involve a multidisciplinary team where a decision can be made to monitor. And if there's increase in size of the tumor, then resection is done, but actually spontaneous regression can occur. And these are children who would be INSS stage 1 or INRGSS L1. Then biologic features of the tumor. When the tumors are well differentiated, these confer much better prognosis. Then there's amplification of the NMYC oncogene. It's seen in about 20% of primary tumors. And unfortunately, it's really strongly correlated with advanced disease and treatment failure. So it's actually a poor prognostic indicator. But when ferritin level is less than 92 nanograms per milliliter and LDH less than 1,500 units per ml, the prognosis is found to be better. So those are workup that can be included at diagnosis to help prognosticate. and also can guide on the treatment modalities, especially on the chemotherapy and how intense chemotherapy can be administered. So we'll move to rhabdomyosarcoma. These are soft tissue sarcomas. Rhabdomyosarcomas are part of soft tissue sarcomas, which are a group of malignant tumors derived from primitive mesenchymal cells. They account for 7% of childhood malignancies and arise from muscle, connective, supportive, and vascular tissue. Generally, these soft tissue sarcomas are locally highly invasive, and they have a high risk of local recurrence. We have two main groups. That's the rhabdomyosarcoma group, which are 40% of these soft tissue sarcomas, and the non-rhabdomyosarcoma soft tissue sarcomas. So the rhabdomyosarcomas, this is the third most common solid extracranial tumor after neuroblastoma and Wilms tumor. And a third of the cases are in children less than 5 years of age. 60% of the cases will be diagnosed in children less than 10 years of age. And there's a slightly higher male, it affects males slightly higher than females with a male-female ratio of 1.4 to 1. And in adolescents, this is even a bit higher. So most cases of these soft tissue sarcomas occur sporadically, as we have said, also with most malignancies in children, but 30% can be having an underlying genetic risk factor. And these include, for example, the p53 suppressor gene mutation. That's the Lee-Fromeni syndrome, which is a familial cancer syndrome. And if it is actually identified in a family, then there is risk of certain malignancies. Then ionizing radiation is a risk factor, and again, neurofibromatosis type 1. Other risk factors, which I may not have encountered, but I saw this indicated that maternal and paternal use of marijuana and cocaine, and also first trimester prenatal X-ray exposure are also considered as possible environmental triggers of a genetic mutation. So the signs and symptoms, again, we say we need to remember that most of these soft tissue sarcomas present as painless masses, and the symptoms will depend on the location and invasion of the adjacent normal structures, as we had mentioned. 20% of these may present with metastatic disease at diagnosis, and that is to bone marrow, lungs, then lymph nodes and bone. The images you see, this is actually rhabdomyosarcoma in the floor of the mouth. You can see it's a place where surgery is going to be quite challenging. And then here we have rhabdomyosarcoma on the forearm. And this actually a differential would possibly be osteosarcoma. And you can see that the mass is quite large. So the primary sites, because again, rhabdomyosarcoma can develop in almost everywhere, given the types of tissues we have mentioned. So muscle, vascular tissue. So the head and neck, that is a favorable site. We have favorable and unfavorable sites, whereby for favorable sites, then again, it's a lower risk group and can do better on treatment. So head and neck, this includes the orbit, but doesn't include parameningeal as a favorable site. But head and neck is orbit, parameningeal, larynx, parotid, the cheek, the oral cavity. And the head and neck is the most common site where rhabdomyosarcoma will develop, so 40% of patients. Genitourinary in 29% of patients. And the favorable sites in the genitourinary region are the vagina, the uterus, or paratesticular. The bladder and prostate are not favorable. Then extremities are an unfavorable site. Also the trunk are an unfavorable site. So in adolescents, it's more common that you find these rhabdomyosarcoma, the primary site being the extremities, the trunk, or the paratesticular lesions. So on histology, what are the histological subtypes that we see? Embryonal is the commonest seen, and many times will present in head and neck, abdomen, and genitourinary tract. Then the botuloid subtype is seen more commonly in the hollow organs, so like the bladder, the vagina, the nasopharynx, and the biliary tree. The alveolar subtype, which is most common in the extremities, trunk, and perineum. but doesn't mean, for example, especially for embryonal and alveolar, that you may not find them in other areas, such as the areas that they may appear more commonly. We also have the pleomorphic and undifferentiated. The image, again, you see here is one which developed and was quite extensive, involving the cheek and all the way down to the mandible. So by diagnosis, again, for rhabdomyosarcoma, a good history and physical exam, which includes measurements of the primary tumor and assessment of regional lymph nodes, and then the basic lab tests, LDH, which we do generally for most of our cancers, but here it tends to be elevated in advanced disease, and the way it trends over time correlates with response to treatment or progression of disease. For the primary tumor, again, CT scan is an imaging that can be done in most areas, and a chest CT scan can be done to look for metastasis. The PET scan can be used to assess primary and metastatic disease, and also it can be used to monitor response to therapy, but certainly access to that may not be as easy as getting a CT scan, but where available, it can be used. If you're going to use it to monitor response to therapy, then it's important that it also was done in the initial assessment. Then a surgical consultation should be done for tumor biopsy, and that biopsy is what's going to be critical to make an accurate diagnosis. So an incisional biopsy would be the gold standard, but at times, depending on tumor location and all, even multiple core needle biopsies are adequate. So staging and risk stratification. So again, as we've said, it's essential to stage fully and also to assign a risk group. And the risk group classification and treatment, these are based on combining the pre-treatment stage, the post-op, we give a clinical group, and then we factor in the histology. And all this will give us a risk group classification. So for prognosis and choosing the systemic therapy, all these things are factored in, especially to this prognosis. The primary site, we've said there are some which are favorable and unfavorable. Histologic type, whether it's embryonal, alveolar, abortiroid, the tumor size, the degree of regional spread, lymph node involvement, whether there is distant metastasis or not, and extent of pre-chemo tumor resection where applicable. So in terms of prognosis of rhabdomyosarcoma, overall, rhabdomyosarcoma should be curable in the majority of children, and a 5-year survival of 70% is expected. But as I present some of these data, some of it is Western, and we find that we don't have our local data to say, to estimate how our survival rates, but this survival of 70% is Western literature. The extent of disease is the most important prognostic factor. In those with localized disease and where it can be completely resected, of course, they will do better than those with widespread disseminated disease. Children who are in the high risk groups and with metastasis, also the outcome is not as good. In Nigeria, they actually looked at the stages of rhabdomyosarcoma at presentation and looked at their outcomes. And for them, those who were in stage 1 were 30%, stage 3 were 34%, and stage 4 were 36%. So even as we say rhabdomyosarcoma is curable in the majority of children and we should achieve cure rates of 70%, when we have 36% of the patients, and actually if you combine stage 3 and 4, we have more than half of the patients presenting quite late, then we may not be able to achieve that cure rate. So we'll talk a bit also about osteosarcoma. Bone cancers are about 5% of the childhood tumors, and the most frequently encountered malignant bone tumors in children and adolescents, we have osteosarcoma being the commonest at 56%, and then Ewing sarcoma 34%, and chondrosarcoma at 6%. So the most common bone cancer we see in children is osteosarcoma. The peak incidence has been noted to increase through childhood and peaks in the second decade, so around 12 years for girls and 15 years for boys, and that coincides with the adolescent growth spurt. The most common sites are at the metaphysis of these rapidly growing bones. So most common site is the distal femur, followed by, that should be proximal tibia and then proximal humerus. and more than 50% involve the distal femur or the proximal tibia. So the most common site is distal femur, followed by proximal tibia, and then followed by proximal humerus. Symptoms of osteosarcoma are usually present for several months before the diagnosis is made. You'll find that many of these children have been having some bone pain. Many times, it's attributed to a fall or some other injury. So an average duration of about 3 months has been estimated of how long children remain with symptoms before they present to a treatment center. And the common symptoms that they will present with are pain at the site of the tumor. That is, in 90% of the children will present with pain at the site of the tumor. A characteristic of this pain is also that it's generally bone pain that wakes these children up at night. Also, local swelling, we tend to see very huge masses, but swelling can be from mild to very large. Decreased range of motion in 45%, and a pathologic fracture in 8%. I tend to think actually this pathologic fracture may be more in our setup. Just because of the late presentation, and with any weight bearing, then we get a fracture. So approximately 10 to 20% of these patients have evidence of metastatic disease at the time of diagnosis. And the most common site of metastasis is to the lungs, but also to other bones. And systemic manifestation of osteosarcoma is rare at the initial presentation. Many times they'll just present with the primary site. So to make a diagnosis, we do our basic workup. The alkaline phosphatase tends to be elevated in many children with osteosarcoma, and is also, that's about 30 to 50% of the patients will have an elevated alkaline phosphatase. So an X-ray of that entire affected bone should be done. The things to look for are the Codman triangle, formation of new periosteum, elevation of the cortex, and even, as you said, a fracture that can be looked for. Imaging of the primary tumor, MRI is very good because it can inform on the soft tissue involvement around the tumor, and also to look into the neurovascular structures, but CT as well can also inform. High resolution chest CT, this is important for staging to look for metastasis, which sometimes are not seen on chest X-ray. The baseline echocardiogram and audiogram, again, are because of treatment, and these are prior to chemotherapy and radiotherapy, but these can be done at a treatment center. Then biopsy and pathologic review, again, are essential to establishing the diagnosis of osteosarcoma. As we've said, there are also other bone cancers, which could be differentials. So the histology of osteosarcoma, you can see, sorry, just to take you to these images, you can see the image on the top. That is actually the femur of a child. You can see the hand there at the top, but that's the femur with a very huge swelling. So a very large mass, and that was an osteosarcoma. And that began at the distal femur and has extended that way upwards. And then from these are X-rays where you can see the arrows are pointing at the periosteal elevation, the Codman triangle. Yeah. So that, and even on this side, and what you call the sunburst appearance. And I think here there is a fracture, and you can see even the bone density, which changes there. So the histologic diagnosis of osteosarcoma depends on demonstration of malignant osteoid, and the classification, we have classic osteosarcoma, which has those three subtypes: osteoblastic, chondroblastic, and fibroblastic. Then we have the telangiectatic, small cell, periosteal, and paraosteal histological subtypes of osteosarcoma. In terms of prognosis, survival rate of non-metastatic osteosarcoma is about 70%, but once we have metastatic disease, this drops to between 10 and 50%. Using chemotherapy has resulted in significant improvement in disease-free survival, but there's also an implication in terms of the types of chemotherapy used. We are sometimes not able to hit the high targets, like, for example, very high dose methotrexate, which has resulted in improved disease-free survival. But neoadjuvant chemotherapy is now advocated for, and the advantages of this are that it will decrease tumor-related edema and it can shrink the tumor, making surgery easier. Initial chemotherapy is assumed to target the micrometastases, which are usually in the chest and are present in 80 to 90% of patients. So even when we don't see the metastasis, obviously on our chest X-ray, there may be metastasis, so this chemo may target that. And also you can assess how sensitive the tumor is to chemotherapy, because if you have more than 90% necrosis when they're looking at it on histology, then this shows actually survival. There's improved survival if you have more than 90% necrosis. But when it is less, you may need to consider intensifying treatment. So finally, we look at brain tumors. Here you see a picture of a child who, this was the only symptom that they had. So a squint that wasn't there before, and that's turned out to be a brain tumor. So tumors of the central nervous system are the second most common group of cancers in childhood, and they account for 20% of all childhood malignancies in developed countries. And they're also, as we've seen from Kenyan data, there's an increasing number of brain tumors being picked up. So I put this image just so that we can at least try and understand the areas from where the tumors are arising. A study was done in KNH, which looked at the delayed diagnosis of childhood brain tumors in Kenyatta National Hospital. And from that study, they looked at the various brain tumors that have presented in KNH. Craniopharyngioma was found to be the most common tumor. Those were 27.9%. You can see where they are, where they would present, in this small region here, so that's craniopharyngioma. Medalloblastoma presented, were the next most common at 16.4%. Then pilocytic astrocytomas contributed to 16.4%. Then the PNET were 9.8%, ependymoma were 6.6%, and brainstem gliomas were 3.3%. So our most common tumors were craniopharyngioma and medalloblastoma at Kenyatta National Hospital. So we've mentioned this, we've just looked at the image. It shows the various locations of the tumor, so of brain tumors. So we have supratentorial and infratentorial lesions. I think the biggest thing in brain tumors is just to note the signs and symptoms to look out for. And usually these will be related, of course, to the location, the size, and the growth rate of the tumor. So when tumors are growing slowly, then there's a period for shifting of normal structures, and these may become quite large before the child is symptomatic, especially if sutures are still open. And for rapidly growing tumors, symptoms will present early, even when the tumors are still small. So the most common presenting sign and symptom of these brain tumors is raised intracranial pressure, followed by focal neurologic deficits. So some of the signs: headaches. In young children, this will present as irritability, which is often worse in the morning and gradually improving throughout the day, and similarly for the headaches in older children. Vomiting, especially in the mornings, and sometimes if the intracranial pressure has increased quite a bit, they may have projectile vomiting. We may note disturbances of gait and balance. Hemiparesis as well may be noted, and cranial nerve abnormalities. There's also impaired vision. You may note diplopia, may be seen in the young children, and this may present actually as frequent blinking or intermittent strabismus. So, and papilloedema may actually present as intermittent blurred vision, which may be seen in slightly older children. Mental disturbances, so somnolence. If a child is just sleeping too much, they are irritable, have had personality or behavior change, or change in school performance. Many times these children are probably being disciplined in school or at home, but a consideration should be made for a possibility of a brain tumor. Seizures, usually focal seizures. And then we may see endocrine abnormalities, especially, for example, in the craniopharyngiomas, as we've mentioned. Then increased head circumference in infants, which is a characteristic of the increased intracranial pressure. So in terms of diagnostic evaluation, CT scan is important. This may detect CNS malignancies, even in up to 95% of these brain tumors. So a CT scan, again, is fairly easily accessible now. That is one procedure which can be done to quickly detect a brain tumor. In tumors of the posterior fossa, and the medulloblastoma is in there, then MRI has advantages. Doing an MRI, of course, there is less or no ionizing radiation exposure to the child. And so even with subsequent MRIs, that confers a benefit. It has greater sensitivity in detecting the brain tumors, especially in the temporal lobe and posterior fossa, whereby bony artifacts on CT may not show the tumors as well. Also, having multiple planes is useful for planning for neurosurgery, for any surgical approaches, though now, there's CT reconstruction that can be done. And also you can apply different pulse sequences to better demonstrate the anatomy, that's in T1 weighted images, and also better demonstrate pathology in the T2 weighted images. So in terms of treatment and prognosis, neurosurgical intervention is key, and mainly this is so that they can provide tissue for biopsy, so that histopathology and cytogenetics can be done on this tissue and helps planning with treatment. We can attain maximal tumor removal with the fewest neurologic sequelae. So sometimes some of these tumors are not accessible, and therefore resection is not an option. Even biopsy may not necessarily always be an option. And also to relieve associated raised intracranial pressure, so by placing a shunt. So most patients with high-grade brain tumors may require radiotherapy to achieve local control of the microscopic or macroscopic residual, especially once surgery has been done. And chemotherapy can also play an important role, usually in recurrent disease and also in newly diagnosed patients, but especially in young children who we may not want to quickly take for radiotherapy, especially those below 3 years of age because of brain development. So thank you. That is what I had for us on these childhood solid tumors, but certainly we will discuss much more in the workshop and cover more solid tumors. Thank you.
Wow, thank you very much, Dr. Muma, for that comprehensive overview for the common solid tumors that we see. And yes, like she said, we are going to have a workshop where we shall go into a lot of details and even cover more solid tumors. Now we shall invite Dr. David Water to take us through the principles of management, an overview only. And the link to the workshop is going to be shared, where we shall have a lot of time to go into the details of treatment and even the other solid tumors that we've not talked about. Karibu, Dr. Water, for an overview of the principles of management.
Thank you, Dr. Nzamu, and thank you, Dr. Sarah, for that comprehensive outline of childhood solid tumors. So we'll just talk a little bit about principles of management of childhood solid tumors. Okay, this is the outline. We look at the role of the multidisciplinary team. We'll talk about early referral, the role of surgery, role of chemotherapy, role of radiotherapy, supportive care, and the post-treatment surveillance. So in management of childhood cancers, it's important to have a multidisciplinary team. And this multidisciplinary approach supports clinical efficiencies and fosters seamless patient-centered care for the patients and their families. Now, we know that there have been many advances made in treatment of cancers in general and even childhood cancers. And these have led to improvement of survival and quality of life for the children. And as Dr. Muma has presented, in the West, they have, even in the developed countries, basically they have very good survival outcomes and better quality of life as compared to the third world. And this is has been achieved a lot through the multidisciplinary approach to care of children with cancer. So it requires pediatric oncology care across the spectrum from diagnosis through to long-term survival. So here at KNH, we have a multidisciplinary care team for pediatric oncology. And the members of the team include pediatric hematologists and pediatric hematology oncologists, pediatric surgeons, pathologists, nurses, neurosurgeons, radiation oncologists, radiologists, clinical pharmacists, the nutritionists, palliative care specialists, the psychologists, and many others. So we are all involved, and we discuss the patients, and we consult widely to ensure that for each child, they actually receive the best care and receive the optimal care depending on their particular diagnosis. Now, Dr. Muma also talked about time of diagnosis. She talked about early diagnosis and late diagnosis. And it's important to note that early diagnosis will require a very high index of suspicion. So especially in the rural healthcare facilities, whenever you see some of those signs and symptoms that are presented, it's important to have that high index of suspicion so that maybe the necessary early tests can be done so that you can establish, could it be a malignancy or not? And if it could be, then the patient is referred to a tertiary center where they can actually get the proper treatment. So this one will lead to improved prognosis and less treatment-related morbidity. And so we always recommend that referral to a comprehensive childhood cancer treatment center to be done rather than sometimes trying to treat these where some of these professionals and facilities are not available. Like I showed in the previous slide, all the members of the multidisciplinary team, all this would be required to be able to actually do a proper treatment plan for the. It's important once you've had that high index of suspicion and you've done the necessary tests to refer them to a proper comprehensive childhood cancer treatment center. Now we look at some of the treatment modalities. So when we talk about treatment modalities for childhood cancers, and Dr. Muma had mentioned the surgery, radiotherapy, and chemotherapy. So briefly, we shall look at the role of surgery. And one of the main roles of surgery is to establish a diagnosis by providing the tissue for biological studies so that the pathologist can look and say what exactly the disease is. And then, of course, it's to, where possible, remove the tumor, so surgical resection. And if possible, to just do a complete resection with the negative margins. In some cases, you may have some cases where complete resection is not possible, so debulking is done. So part of the tumor is actually left while a chunk of it is removed. Biopsy and pathological review are essential to establish a diagnosis for most of the solid tumors, and it should be performed by pediatric surgeon or interventional radiology. So when it comes to biopsy, there are some cases where an open biopsy may not be done, and so an interventional radiologist may be required to be able to access that particular and actually do the biopsy so that it can be sent for review by the pathologist. An open biopsy or image-guided percutaneous core biopsy can also be performed, for example, for abdomosarcoma and osteosarcoma. So surgery is most effective if the tumor can be completely excised with adequate margin of uninvolved tissue. So for surgery, we always hope that you're able to do complete resection with negative margin. So there is no tissue that is left behind. So this will enable the surgeon to achieve local control of the disease. In some cases, surgical resection may result in major functional or cosmetic sequelae, and this one will generally be avoided. So some examples in like if you're talking about a hepatoblastoma and a big percentage of the liver is involved, then it may not be possible to remove a big percentage of the liver because that will affect the whole physiology of the patient. And timing of surgical resection is also dependent upon radiographic features, response to treatment, and upon a patient's risk stratification. So we look at chemotherapy. So chemotherapy is widely used in management of the solid tumors. So most of the solid tumors, maybe except a few brain tumors, will require chemotherapy. So chemotherapy is usually will be useful for systemic control. And it's important to note that treatment duration varies. So it may take very long. So the child would either require to come to the hospital maybe every week or every 3 weeks, but on a regular basis just to get that chemotherapy. In some cases, they may require admission for that type of chemotherapy, but in other cases, they may be able to receive that chemotherapy as daycare chemotherapy. And so as the multidisciplinary team will decide whether this particular type of chemotherapy can be done as outpatient or as inpatient. If it can be done as outpatient, then for the family, gives them a little bit of flexibility in terms of them continuing with their other activities. But if it requires inpatient, then it means the parents will have to come and in some cases stay with the child at the ward until they finish the chemotherapy cycle and then go back with them home. So this one tends to disrupt some of the daily family activities. So chemotherapy may be oral or IV. Now it's important to note especially for oral chemotherapy that it may require additional counseling in terms of medicine use. And this is so because there tends to be a general feeling or a general perception that if it's not given IV, it's possibly not chemotherapy, or the oral chemotherapy could be assumed to be as like the other medicines, for example, your analgesics and such. So someone may not take it seriously as they take the IV medicine. And also for oral medicine, if the patient goes with those medicines to their home, you're not sure if they took the chemotherapy or not. At least for IV, you know that you gave the medicine, but for oral, you may not know. And then again, they need to store the medicines properly so that other family members don't access these medicines and use them for their for themselves. So for childhood cancers, we'll mostly have the conventional anti-cancer chemotherapy. When you compare to the adult cancers, they have fewer options in terms of targeted therapies, but there are some targeted therapies that can be used. For example, bevacizumab for some of the brain tumors. We'll talk of things like everolimus for neuroblastoma. So there are some targeted therapies that can be used for the pediatric cancers. So patients with localized disease will require systematic therapy to eradicate the necrometastatic disease that may present at diagnosis. So chemotherapy may be neoadjuvant, so given before surgery, or adjuvant, that is given after surgery. Some chemotherapy can actually give it in a palliative setting, so we just give to try and do disease control, not expecting any changes to occur, but to just minimize the symptoms. And this one will require use of guidelines and protocols, accurate dosing and monitoring for early and late side effects. Then also safe handling of chemotherapy is required, both from preparation to administration, to transport and to disposal of the same. Looking at radiotherapy, so radiotherapy is also an important component for management of child solid tumors. So radiotherapy will normally be given in phases. So they normally get maybe from, depending on the dose, maybe from day 1 to 20, day 1 to 30, depending on the dose and the schedule that the radiation oncologist has decided. So this one also requires the patient to come on a daily basis to the hospital to get the therapy. So it has a therapeutic role in management of the high-risk Wilms tumor, and the high-grade brain tumors. Can also be used in a palliative setting in the rhabdomyosarcoma, in brain tumors, and also for pain management. It also has a role in oncologic emergencies. For example, in spinal cord compression and the compromise. Post-radiotherapy surveillance is necessary for long-term side effects such as variable degree of scoliosis, organ hypoplasia, and secondary malignancies. So it's always important to follow up these patients who've done radiotherapy. We look at supportive care. So nursing is very important, especially in management of oncologic emergencies and support during all phases of treatment. Remember, administration of chemotherapy will normally be the role of the oncology nurse. And so they have to monitor for the immediate side effects and aspects such as hypersensitivity reactions. So these ones need to be monitored closely. Palliative care is also important. It begins at diagnosis and continues throughout the whole treatment continuum and follow-up of the patient. So it involves the active total care of the child's body, mind, and spirit, and also involves giving support to the family. Nutritional support is very important. And it's been noted that many of the children who present to the hospital would normally have some severe malnutrition. Pain management where applicable. And just note that chemotherapy and radiotherapy can be used in the palliative setting. So post-treatment surveillance, so once the child has been treated, it's not the end. They still need routine monitoring and follow-up. So routine monitoring is required, especially one, to monitor for the side effects of the medicines, the anthracyclines, because of the cardiomyopathy, medicines because of the renal impairment, chemotherapy and radiation induced risk for secondary malignancies, infertility. So some of the medicines given to the children can actually affect their ability to reproduce when they get to that age of reproduction. And also it can cause growth and development deficiencies. All these need to be monitored. So then there normally needs to be a follow-up and survivorship plan for the children who have just completed treatment. Risk for disease recurrence is highest in the initial 2 years following completion of therapy, but relapses can also occur. And the post-therapy surveillance recommendation and monitoring should be done in a comprehensive survivorship clinic. So you have a mix of specialists in this clinic who are able to follow up these types of patients. So you'll have an endocrinologist there, you'll have a psychologist there, you'll have a pediatric oncologist there to just help in follow up and in monitoring these patients. So some of the activities you also do in management of childhood cancer is just to increase the public awareness of signs and symptoms of cancer, like we are doing in this workshop and also in the in the symposium that is coming in the next couple of weeks. Training health workers so that it can raise the index of suspicion, development of guidelines for early referral, and training of specialists of all cadres, development of treatment gain, addressing social and financial barriers to treatment. And I think with that, we've come to the end of the presentation. So we'll take it back to Dr. Nzamu. Thank you.
Thank you very much, Dr. Wata. Very comprehensive, the principles of management for our solid tumors. So we've come to the session now for Q&A. And I know most of you have asked your questions and we've answered in the Q&A chat. But we have some members who have raised their hands. I presume they're having questions. We can start with Maureen Muchela. We saw your question, we responded, but Dr. you could go ahead. Dr. Muchela.
Thank you for your presentation. I actually asked, I haven't looked at the answer. For Kisumu, we are getting, I hope you're getting me.
Yes.
Severe presentations for nephroblastoma, and it's actually heart-shattering. Out of very few patients, I think we only have one success story. They present with all sorts of metastases. And currently we have a child who we even referred now to MTRH. We gave up and referred a child who had presented with nephroblastoma but had intra IVC extension of the tumor. But now came back to us, the tumor recurred within 1 month of finishing chemotherapy. And we're just wondering what to do with the child palliatively now. So maybe some guidance on that.
Okay, Dr. Thank you for that question. And we had also seen it and commented, maybe you'll see the answer there. And we had thought in terms of asking you how your histologies are looking like, because like Dr. Muma presented, could be that with such poor outcomes, is it that your patients are having high-risk histology and they're high-risk patients who need more intensified therapy, because now we are giving risk-based therapy. They are all not getting the same thing. We had wanted to ask you, how are your histologies for all these really bad outcomes that are happening in Kisumu?
Sorry?
We can look at after this. We can look at it after this meeting.
Yeah.
Yes, I think so. But I'll ask Dr. Muma to make a comment, even as we follow up with you, just to list them down and let's see how their histologies looked like to see if there is a pattern. Dr. Muma?
Yes, thank you, Dr. Irene. I do agree with you that it's possibly the risk stratification. As I mentioned, 40% of the relapses that are seen is because the patients are not classified as high risk. So we need to actually look at those histologies and see whether you would have been able to intensify your treatment. And also, are these children getting radiotherapy if they required it and on time? So those are the main things that we would look at, and we would be glad to support the team in Kisumu so that we can achieve better outcomes. Thank you.
Thank you, Daktari. We have a new question coming through in the chat from an anonymous attendee who is asking, are there any risk factors for childhood tumors, generally and specific to the tumors? Risk factors, I would probably ask our colleague, Dr. Olbara. This is our colleague, Gilbert from MTRH, pediatric hemato-oncologist. We are working very well together. Dr. would you help us to take that one? Are there any risk factors for childhood cancer? Dr. Olbara?
So thank you, Dr. Irene Zamu, and thank you, the KNH team, for this wonderful presentation. Thank you, Dr. Sarah Moman. So for cancers in children, there are very few associated risk factors. Actually, less than 10% of the total cancers in children have an associated risk factors, particularly more so in the acute leukemias. Then additionally, there are just very few that have hereditary associations, and what Dr. Sarah Moman has already mentioned, those which have a predisposing genetic condition or congenital condition. And these are mostly sometimes in the leukemias, in the Wilms tumor, and the one which is hereditary is the retinoblastoma. So otherwise, apart from that, there are no really close associations that have been made. There are a few things that are exposures, but these have not been very well proven. This is quite different from what we see in the adult population, where we have more cancers having risk factors and associations. And my take-home message is that this also means that since there are no significant associations, we, the healthcare workers, are the best chance for our children, because when we recognize these signs and symptoms, any child who walks to you may not have a risk factor, but they may come with a disease, and recognizing them early is the best options that we can actually increase their outcome and their survival. So I think that is my thought and my take.
Thank you very much, Dr. Obara. We have one more that has come through. As we wait to see whether Dr. Grace Muteshi, your hand is up. You could ask your question, Grace Muteshi. The hands that are up, if it's a question, kindly indicate. Grace Muteshi, Francis Mweu, your hands are up. Meanwhile, as we wait for them to ask, there's a question that has come through. It says, kindly elaborate on lifestyle modifications we can recommend for these pediatric cancers. Is there anything they can consume to expose them to more risks? So again, a question on issues of risk factors, lifestyle. Is there anything that can be done? Dr. Wata, would you like to take that one?
Thank you, Dr. Nzamu. I think it has already been noted. There's very little in terms of risk factors, in terms of the association to pediatric cancers. So there is, and I haven't seen any studies which will associate your diet, for example, and the things you eat to the cancers, though the main thing will still apply. For example, the ionizing radiation, but which in some cases we may not be able to do much about. But otherwise, in terms of your diet, I think if your children take a balanced diet, they'll be good in terms of just preventing your ordinary nutritional deficiencies. But otherwise, in terms of the relation to cancers, there's nothing much you can do in terms of diet.
Thank you, Daktari. And so it's for us who are here, 1,000 people on this forum, just to keep spreading that message as we create awareness on childhood cancer, that really it's not about lifestyle or diet, like we've learned in today's session. Francis Mweu would like to ask his question. Admin, kindly allow him to be able to speak. Francis Mweu. He would like to ask his question verbally. Francis, you can go ahead. Please unmute yourself, Francis Mweu. You're still muted, Francis. Okay, as we wait for Francis to unmute, John Gatabaki, go ahead. John, you're muted. Please try to unmute. So we have John, Rachel, and Rehema. And if you're unable to unmute, it's okay. You can type in the chat, like many people typed their questions and you were able to answer. So we go back to the chat. Penina is asking, I am wondering if there is a variation by county or by geography in the childhood cancer prevalence or incidence. Dr. Muma, is there a variation by geography?
Thank you, Dr. Irene. I think the variation that we see currently may be just because of the way, as we've mentioned, picking up and noting these early signs and symptoms. So you may find that in certain areas, the healthcare workers have been sensitized, they are a bit more informed, they are more aware, so they are looking out for these children. We know that there are programs which are trying to reach out to the periphery where we may not have access to have a pediatric hemato-oncologist or someone or an oncology nurse who can identify these children. But we know, for example, there are programs where we're having virtual sessions, we're having online meetings, so the awareness is increasing. So we might see a slight variation because of that, but that doesn't necessarily mean that this variation actually that the children in certain areas are having more of those cancers. So I would say the variation we see in Kenya at the moment, we may not be able really to attribute it to true difference in the prevalence of the incidence. It's more, we still need more years before we are sure we are just picking them up from every area, and now we can investigate further and see whether there are areas where there are certain cancers that are more prevalent. Thank you.
Thank you very much, Daktari. We are doing well in terms of time. We've answered all the questions in the Q&A chat. And for the members whose hands were up, I can see now all the hands are down. So maybe they didn't mean to ask questions, but we are still available to answer more and more. I'm going to request our admin from KNH Research and Programs to now come on board and take us through the questions on CPD. There's a lot of concern on CPD, and also to invite us to the workshop that is coming up. Karibu admin, Nelson. Can you hear Nelson?
No.
No, admin, we can't hear you. Kindly check your audio.
Yes, Dr. Irene, yes, I could hear you. For the issues of CPD, most of them were directed to PPB, and we would like to notify you that all of this week's webinars have been uploaded to the portal, including the ones for last week. We are planning to send the CPDs for today's session immediately after the session. So if you haven't subscribed, kindly please subscribe for the event so that you can receive the points for today. We will be sending the previous CPDs as well throughout this week. So kindly just go ahead and subscribe if you hadn't subscribed so that we can get you your CPD points. Thank you. For nurses, you will be receiving the points today or tomorrow. And for KMPDB portal, you will be receiving your CPD tokens through your email addresses. as usual. So thank you so much for your questions on CPD. We have tried to fix that issue, and we are glad that all the sessions have been uploaded to the PPB.
Thank you very much, Nelson. And finally, as we come to the end of the meeting, we also want to take this chance to invite all of you on 20th and 21st of September, as we have the workshop on pediatric oncology. Nelson will be sharing the link. You can register online so that we can continue having these conversations on how best to care for our children who have cancer. And so at this juncture, I'll just welcome Dr. Muma to make some closing remarks as we end the meeting. Karibu, Daktari.
Thank you very much, Dr. Irene. Yes, this is the Childhood Cancer Awareness Month. So I want to just say thank you very much for attending these webinars, and we really do look forward to seeing and having a great attendance also at the workshop. And also this is a month to spread the knowledge and the information, especially on how to note these signs and symptoms of childhood cancer early and refer these children early for treatments. Yeah, so I wish everyone a wonderful afternoon. Thank you.
Thank you, Daktari. Dr. Obara, parting shot. Unmute, Daktari. Gilbert, please unmute for your parting shot.
Sorry. Oh, thank you. So I'm saying thank you, Dr. Sarah, for that very wonderful presentation, and it couldn't have come at the best time. It is for us to encourage our healthcare providers that we are the biggest and the best chance for our children. Early recognition, early referral, early consultation with the networks. That is why we attend these meetings or we present this, so that when you have an idea, when you have a question, you know whom to call, how to refer the patients. And we need to be on the lookout. Unlike other devastating or other diseases, childhood cancers can just present like any other. We mentioned TB, we mentioned malaria. So we need to have a high index of suspicion. And what we really need is just to have an index of suspicion, refer the patient for workup. Then the people who are specialized or people who are in the facilities that have the capacity will make the diagnosis. Thank you. Have a happy September month, which is a child's pediatric oncology month. Thank you so much.
Thank you, Daktari. Dr. Wata, your parting shot. And members, the link is being shared, so those who want can register for the workshop online. Wata?
Thank you, Dr. Nzamu. Let us network, let us talk when it comes to pediatric cancers, childhood malignancies. Let's talk. If you have a child, just call KNH or call MTRH. Let's talk so that we can help one another. If you have a difficulty, just call in terms of anything so that we can help one another and we can help the children. The other thing is the workshop. The workshop is on 20th, 21st. Please come in large numbers. Thank you.
Thank you, Daktari, and thank you everyone who attended. So from us, it's bye-bye. We look forward to seeing you at the workshop. Have a very good afternoon. Thank you. Bye, everyone.
Bye-bye.